Hello again, dear colleagues, dear viewers. Now we are in the last session of the second day. There are lectures in it, and Professor Senaroğlu is going to moderate. So please, Levent, can you take speech and begin with the session? Thank you.
Thank you very much, Dr. Özgürgen. We are in the final part of today's program. We have 5 speakers, and please remember that you can send questions written in the web page, and I will forward the questions to the presenter at the end of his talk. And we begin with Professor Nazım Korkut, who is from the Acıbadem Healthcare Maslak ENT Department, Istanbul, Turkey. He's an eminent otologist dealing with all aspects of vertigo, from medical treatment and surgery. He was also past president of the Turkish Otologic Society, and he's going to talk about vestibular paroxysmia. Professor Korkut, please.
Thank you, Levent. Can you hear me?
Yes, very well.
Yes. Good afternoon to everyone. First of all, I would like to thank my dear friend Nuri Özgürgen. Thank you so much. I am so happy to be a part of this amazing event. I'm going to give you a presentation on vestibular paroxysmia. This clinical entity, previously defined as neurovascular compression syndrome by Janetta, 1975, and later named disabling positional vertigo by Janetta again, 1984. And then nowadays it referred to as vestibular paroxysmia. The term vestibular paroxysmia was introduced for the first time by Brandt and Dietrich in 1994. Yes, this clinical entity was first described by Janetta as neurovascular compression syndrome. These patients have hyperactive dysfunction symptoms of the 8th cranial nerve. Arteries and veins compresses some cranial nerves at cerebellopontine angle. And compression on the nerve leads to some symptoms. Most common neurovascular compression syndromes: trigeminal neuralgia, compression of the 5th cranial nerve, hemifascial compression of the 7th cranial nerve, vestibulocochlear compression, compression of the 8th cranial nerve is our topic today. Also pharyngeal neuralgia, etc. Vestibulocochlear compression. This syndrome is a symptomatic vascular compression of cranial nerve 8. Clinical symptoms are often non-specific, including tinnitus, vertigo, sensorineural hearing loss, motion intolerance. In decreasing order or frequency, VASs indicated vascular compression syndrome include the AICA, anterior inferior cerebellar artery, posterior inferior cerebellar artery, and vertebral artery. Now let's talk about its current name, vestibular paroxysmia. In 2016, the Barani Society formulated the International Classification Vestibular Paroxysmia, focusing in particular on the number and duration of attacks, on the differential diagnosis, and on the therapy. The diagnosis of vestibular paroxysmia is mainly based on the patient history. Sorry. According to Berlin Society, there are two types of vestibular paroxysmia, definitive and probable forms. This is a definitive form, at least 10 attacks of spontaneous vertigo, duration less than 1 minute. Stereotyped phenomenology and a particular patient responds to a treatment with carbamazepine or oxcarbazepine, no better accounted for by another diagnosis.
Dr. Korkut, you can use the
Thank you. Excuse me. Probable form, at least 5 attacks on spontaneous vertigo, duration less than 5 minutes. Spontaneous occurrence or provoked by head movements, not better. Chronic, longer than 3 months. Short attacks of rotatory or postural vertigo last 4 seconds to minutes with instability of posture and gait. Attacks may often be triggered by particular head position or hyperventilation and may be influenced by changing the head position. Unilateral sensorineural hearing loss or tinnitus occurs during the attack occasionally or permanently. The frequency of attacks varies greatly among patients, from 30 attacks per day to a few attacks per year. Attacks are improved or lessened by carbamazepine, of course. No central vestibular ocular motor disorders or brain signs are present. Pathophysiology. It's assumed the short attacks of vertigo are triggered by epileptic discharge. Epileptic discharge in the proximal part of the 8th cranial nerve, which is covered by oligodendrocytes. The likely site of the lesion is central, proximal to the transition zone. This corresponds to the first 15 millimeters after the nerve exit. What are potential causes for the nerve injury? Focal irritation by blood vessel, tumor, cyst, compression, demyelination, trauma, etc. As you can see here, root entry zone and transitional zone. This is completion point by AICA. Transition zone, this is transition zone. You can see here at this completion point, root entry zone. You see, anterior inferior cerebellar artery, facial nerve, vestibulocochlear nerve. Yes, here repeated vascular pulsation at the vulnerable transitional zone of the cranial nerves lead to focal axonal injury and demyelination. What are laboratory findings? Sensorineural hearing loss in audiogram, auditory brainstem response alteration because retrocochlear pathology, maybe. Vestibular hyperfunction, maybe. Hyperventilation induced nystagmus. That's matter. Identification of the affected site is often not possible. Approximately 50% of patient audiovestibular unilateral hypofunction during the attacks-free interval. But MRI is very useful identification of the affected site. On the other hand, bilateral neurovascular compression was found in 42% of this patient. Differential diagnosis. This disease very confused, but it is necessary to carefully examine the clinical and laboratory characteristics of each disease: benign paroxysmal positional vertigo, vestibular migraine, Meniere's disease, brainstem attacks due to MS plaques or lacunar infection, phobic postural vertigo, superior canal distance syndrome, panic attacks, etc. A lot of reason. MRI for differential diagnosis. MRI is the most important diagnostic instrument. In differential diagnosis, various intracranial pathologies can also be recognized by MRI. You see here a lot of intracranial pathology, schwannoma, meningioma, multiple sclerosis, other tumors, etc. MRI is very useful for both differential diagnosis and diagnosis of vestibular paroxysmia. As seen in this study of 32 patients with vestibular paroxysmia, neurovascular compression of the 8th cranial nerve was detected in 95% of the patients. Bilateral neurovascular compression was found in 42% of the patients. The other paper, compressing vessels are seen in the study, 15 cases, compressing vessel in order to anterior inferior cerebellar artery 75% first, and posterior inferior cerebellar artery 5%, vein 10%, and 2 cases vertebral artery. Yes. This is normal anatomy in cerebellopontine angle, fascial and vestibulocochlear nerve. These are systemic parts. Okay. Which images are more useful, especially T2 weighted sequences? CISS and Fiesta sequences are useful, more useful. The other sequences, TOF sequences in MR angiography is very useful sequences. How is ICA's position in cerebellopontine angle? There are 3 types of ICA course. Type 1, lying only in the cerebellopontine angle, but not entering the internal acoustic canal. Type 2, entering but not extending more than 50% of the length of the internal acoustic canal. Type 3, extending more than, 50% of the internal acoustic canal. This is a type 2 example, and type 3, as you can see here, yes, ICA is quite inside in the internal acoustic canal. Some studies on this region are available in the literature. External length or transition zone of the cranial nerves 5, 7, 8, and 9 cranial nerves. The longest transitional zone you see vestibulocochlear nerve. Incidence of symptomatic neurovascular compression syndrome, trigeminal neuralgia is most common, you see. Vestibular paroxysmia, unknown, glossopharyngeal neuralgia is very rare, as you see here. What are we doing as treatment in these cases? Spontaneously resolve. Neurovascular cross-compression may resolve spontaneously since vascular, brain, and bone structures grow at different speeds. We have a two-type treatment protocol, medical and surgical treatment. Medical treatment, there are no data available from randomized prospective placebo-controlled studies on the efficacy of various drugs in vestibular paroxysmia. Carbamazepine or oxcarbazepine are most commonly used antiepileptic drugs. Other drugs, very limited evidence for the use, lamotrigine, baclofen, topiramate, gabapentin, etc. One of the various medical treatments of vestibular paroxysmia in the literature, 3-year period revealed a significant and continuing decrease in the attack frequency down to 10% of initial value. It is important. Medical treatment. A positive response supports the definite diagnosis. This is an important point in medical treatment. Surgical treatment is microvascular decompression, as you know. A Teflon pad is placed between the nerve under compression and the vessel. This is Teflon pad. Success rate in large series are 80%, but surgery has significant risk, brainstem, such as brainstem infarction, either intra or postoperative vasospasm, 5%.
Dr. Korkut, 1 minute.
1 minute, yes. I am finishing talking now. Its operation site is difficult to determine the affected site with enough certainty. The other method. Finally, I would like to talk about some questionable issues. Epidemiological and clinical features of vestibular paroxysmia, including the nystagmus during the attacks, are not well known. Since there are no tests to prove the diagnosis of vestibular paroxysmia, further multi-center studies are needed to improve phenotyping, including familial history of vestibular paroxysmia. Thank you very much for your attention.
Thank you very much, Dr. Korkut. There are a number of questions. One is the severity of the symptoms in vestibular paroxysmia related to Chowda grading in MRI?
Sorry, Sean?
Is the severity of the symptoms in vestibular paroxysmia related to Chowda grading, CHAVDA, grading in MRI?
Grading, yes. DA, Dr. Leo, DA grading.
Yes. Is there any relationship between the
severity cases? Yes.
Somebody from India is asking, hyperventilation-induced nystagmus, what are the characteristics in terms of, but this is not very related to our...
Hyperventilation is a useful test in diagnosing disorders of the vestibular nerve. We see 50% of patients hyperventilation induced nystagmus. Hyperventilation affects on lowering the concentration of carbon dioxide in the blood. It's an indicator of damage to the vestibular nerve or central vestibular pathways. In normal persons, hyperventilation-induced nystagmus is a low amplitude downbeating nystagmus. It usually beats towards the side of lesion such as acoustic neuroma or vestibular paroxysmia. We see the other pathologies such as migraine, vestibular migraine, Meniere's disease, multiple sclerosis, brain tumors, and stroke, etc.
One last question. Is there any role of lacosamide in vestibular paroxysmia? Lacosamide. Is there any role of lacosamide in vestibular paroxysmia?
I don't have any idea. I don't have. No idea.
Thank you very much, Dr. Korkut. Now we move to the second presentation by Professor Tayfun Kirazlı. Professor Kirazlı is a professor and head of the Department of Otolaryngology in Ege University, Turkey. He's dealing with otology, all aspects of otology and neurotology. And he was also past president of Turkish Otologic Society. And he is going to talk about vestibulotoxicity. Dr. Kirazlı.
Dear colleagues and dear moderator, before beginning my presentation, I would like to thank our dear friend Nuri Özgürgin for organizing this wonderful meeting. Today, I'm going to talk about an overview on vestibular toxicity, and mainly my topic will be on how to monitor vestibular toxicity, how to monitor these patients in clinical way. Of course, we have to my slides are not working, sorry. Did you see my slides?
Dr. Kirazlı,
Okay. So, if you want to define vestibular toxicity, we also define the ototoxicity. It is the tendency of certain therapeutic agents and other chemical substances to cause functional impairment and cellular degeneration of the tissues of the inner ear, and especially of the end organ. Frequently used drugs in medicine have potential inner ear risks, as all we know. Damage to the inner ear from these agents remains a concern for patients being treated for potentially life-threatening conditions. In vestibular toxicity, the damage is unpredictable, so monitoring the auditory and vestibular function during and following treatment is very important. Although the concern about ototoxicity is not a new issue, but currently we don't know the exact mechanisms of auditory and vestibular losses. Also, we don't know how to evaluate of patients undergoing exposure to these drugs, especially in terms of evaluation of vestibular system and its symptoms in clinic like oscillopsia and postural instability. In contrast, also in particular, we may use the vestibular toxic effect of these drugs as an example of gentamicin in the treatment for vertigo and Meniere's disease. Monitoring of the vestibular function is also important during these applications to measure the effect of therapy objectively. Clinical features of the vestibular ototoxicity are generally depends destruction of the vestibular system as unilateral or bilateral. Oscillopsia, which is the perception that viewed stationary objects or surroundings move coincident with head movement in bilateral involvement. We may also see dizziness, motion sickness, and unsteadiness when standing or walking, especially in dark, and this is a very serious symptom that the patient may fall down and the end result will be life-threatening. In unilateral vestibular paresis or non-lateralized vestibular loss, symptoms may include vertigo, nausea, and general disequilibrium. When a bilateral weakness is present, asymmetries in vestibular function between the ears may occur, resulting in a symptom profile that is consistent with both a bilateral and unilateral vestibular loss. Clinical findings and tests for evaluation of the vestibular investigation mainly depend on disruption of three reflexes, which were discussed yesterday. There is no generally accepted protocols for monitoring vestibular function during or following exposure to potentially ototoxic agents. It's mainly due to expense associated with laboratory equipment. It's also due to patients receiving ototoxic medications may be too ill to fully cooperate with formal testing. The vestibulo-ocular reflex is evaluated by observing eye movements in the bedside setting and by recording eye movements in the laboratory setting using electrodes or infrared video technology. Individuals with canal paralysis will demonstrate a catch-up saccade when the head is rotated quickly to the site of the weakness, while the patient focuses on a stationary visual target. This test, as all we know, is a head impulse test. We may also objectively evaluate head impulse test with video head impulse test. So we evaluate all three paired semicircular canals also. Vestibular spinal reflex, we may evaluate the patient by body position, and we may evaluate patients by formalized or bedside test of balance like Ramberg or Fukuda stepping test. Vestibular colic reflex is a component of VSR. Vestibular colic reflex is evaluated only in laboratory using vestibular evoked myogenic potentials. In this slide, we are seeing the test that we are applying in vestibular toxicity. Some of them are bedside tests and some of them are laboratory tests. The combination of those tests also provides individual ear data as well as information about the VOR across a wide frequency range. Video head impulse testing may prove to be a valuable tool for screening, although head accelerations are fairly high. If laboratory testing is not possible, dynamic visual acuity is an informal test that is also incredibly valuable. In this simple test, we may ask the patient read something from a book or magazine with head still, followed by having the patient read the same passage while moving the head from side to side or up and down at 1 to 2 Hz. If the patient is able to read without head movement, evidence of oscillopsia is not present. A new and promising laboratory tool, functional head impulse test, it was also discussed yesterday. During the test, the participant is expected to look at the Landau's C optotype in 8 possible orientations that appear randomly on the computer screen. Then we ask to recognize it and select the correct C optotype while his or her head is being turned. So the percentage is considered as reflection of high frequency dynamic acuity, which is accepted as R number under the 80%. This is a wonderful tool for evaluating the head impulse test with dynamic visual acuity. We also should apply patients from the beginning of the symptoms and inventory. We generally use Turkish version. The business handicap inventory is a validated measure that is intended to assess the impact of business and unsteadiness on a person's quality of life, and it helps us to follow the clinical course after the rehabilitation period. I will shortly go on laboratory tests. Video nystagmography, electronystagmography is a wonderful tool. We may examine and evaluate each ear separately by using caloric testing. Rotational testing is a valuable but expensive tool. It evaluates frequency range of vestibular function over time related to toxic agents. Similar to ototoxic hearing loss, it may be that change in vestibular function manifests earlier for some frequencies of rotation than others. Static balance and posturography is also a good tool which serve as a gold standard test for evaluating an individual's ability to use vision, proprioception, and vestibular system input for the maintenance of upright stance. Also, we use this laboratory testing in post-rehabilitation periods. Vestibular evoked myogenic potential helps us to evaluate the ventricular function of the inner ear. And VAMP testing has been used to demonstrate loss of sacral function following intratympanic gentamicin treatment in patients with Meniere's disease. We also did an investigation in 2010. We used single-shot low-dose intratympanic gentamicin in Meniere's disease, and we looked at the role of vestibular evoked myogenic potentials and caloric testing in the prediction of outcome. Specifically, while most patients exhibit VAMP responses prior to treatment with intratympanic gentamicin treatment, VAMPs were absent in all treated patients. So we concluded that the single-shot low-dose buffered intratympanic gentamicin is comparably effective with higher dose and multiple shot regimens. So the audiological results were excellent, and we conclude also that if VAMP was present before intratympanic injection, using VAMP for follow-up was more effective than using caloric testing. Also, this investigation, this paper was referenced by American Academy of Otolaryngology and Neck Surgery's clinical practice guideline in Meniere's disease. At the end of my presentation, I would like to speak on therapy in vestibular ototoxicity. The role of vestibular rehabilitation is to promote central nervous system compensation and substitution when a cellular vestibular loss is present, to promote adaptation and to facilitate habilitation of symptoms that are associated with vestibular loss. More specifically, compensation activities stimulate the remaining sensory, motor, cognitive, and neurological systems so they can take over, while adaptation activities provide to generate new neural activities. Individuals who fail to compensate despite rehabilitation therapy have no adequate treatment options currently. However, analogs to hearing restoration via cochlear implant, prosthetic electrical stimulation of the vestibular nerve branch called head motion has gained interest as a potential treatment. This will be the future treatment of the bilateral vestibular losses. Dear Levent, I hope that I finished my presentation on time for the questions and comments. Thank you very much for your attention.
Dr. Kiraze, thank you very much. It was a very concise talk. I have here two questions. One question from Algeria, Dr. Alon. He is asking if you see vestibular toxicity with chloroquine.
Yeah.
Chloroquine. Do you have any experience with that, Dr. Kirazlı?
This is a known drug, you know, during the COVID pandemic, we use the drugs like that, but this mainly affects, to my knowledge, not vestibular system, but first the cochlear system. It's a very known drug that was used in malaria, you know.
Yeah. The second question is also from India, Dr. Kasad. He's asking how to manage a case of vestibular toxicity apart from stopping the offending agent, any role of systemic steroids. He's asking whether we can continue to use the drug while can we use steroids in the meantime?
Yeah.
That's
This
his
is
question.
a very excellent question. You know, in cochlear toxicity, we have monitoring programs like high frequency audiometer, cochlear investigations, or so on. But still, we don't have any vestibular monitoring program. It is the best tool, to my opinion, is the rotatory chair. But it's as I mentioned in my presentation, that it's a very expensive and very valuable tool, but expensive tool. I think that like an audiometer, we may use a vestibular rotational chair to investigate the early effect of vestibular toxic drugs, but we don't use any steroids. I mean, intratympanically or something to avoid the vestibular toxicity. We use, you know, these steroids in cochlear toxicity.
So you don't use steroids for if there's vestibular toxicity, is that?
Is the question about the intratympanical administration? We don't use.
Okay. Dr. Kirazlı, thank you very much for your presentation and questions.
Thank you, Levent.
We move to Professor Avi Shupak from Israel. He is the head of the Otoneurology, Carmel and Lean Medical Center. He is also professor in health sciences and clinical professor in Faculty of Medicine in Technion Faculty of Medicine, Haifa, Israel. And he's going to talk about motion sickness. Dear Avi, the floor is yours. Thank you.
Thank you, Professor Senagulu, for instrumental moderation. And thank you, Professor Özgürgin, for this novel incentive and opportunity to present here. We'll just share my screen. Okay, so in these 15 minutes, I will try to cover the essence of this interesting topic, motion sickness. Try to just cannot move ahead for some reason.
You can just click on
Okay, I got it. So one should appreciate that motion sickness is a normal physiological response, one usual perception of motion, whether real or apparent. Now, a prerequisite to the development of motion sickness is normal vestibular function. Without normal vestibular function, there would be no motion sickness. People with bilateral vestibular loss do not suffer from motion sickness. Now, there are many forms of motion sickness, and it depends on the type of non-terrestrial provocation that one is exposed to. We have car sickness, sea sickness, air sickness, amusement park ride sickness, space sickness, simulator sickness, cyber sickness, ski sickness, cinema sickness, and also in the era of autonomous cars, we have also car sickness, which is a big issue because it is against the notion that we can use the autonomous car as a surrounding, a usual surrounding that can comply to everything we want to do in it. We have to take into consideration ergonomics that will make motion sickness a problem here. Now, what is the classical clinical picture? We have autonomic nausea symptoms in sequential pattern. We have pallor, cold sweat, epigastric discomfort, nausea, emesis. Some people reach the emesis stage rapidly, and early signs may not be encountered. Others suffer severe nausea but never vomit, and this usually experience the most discomfort due to motion sickness. Now, a very interesting phenomenon is the Supite syndrome. This is a special cognitive effect of motion sickness, where one has loss of drive and concentration, drowsiness, apathy, depression, feeling of impending doom, unsocial and encapsulated behavior. And this might accompany prolonged motion sickness situation, such as sea voyage, especially when the stimulus is close to the susceptibility threshold of the individual. Now, what is the prevalence of motion sickness? Motion sickness is rare in children younger than 2 years old. They peak at the age of 3 to 12 years, and then there is a gradual decrease thereafter, as you can see here. Now, the reported prevalence in children with exposed to motion condition is about 43% in car and on bus, about 11-12% on parking swing, Ferris wheel, and these are the most provocative situations. Now, in adults, according to a recent study from Huppert et al., the prevalence is about 13.4%. The rates are higher in female across all age groups, and there is increased susceptibility during menstruation and pregnancy. Now, people of Chinese origin are more susceptible than European, which has the same susceptibility as African. Interesting enough, aerobic fitness would cause higher susceptibility to motion sickness. Probably this is related to increased vasomotor activity. Now, by age, there is variability of the clinical presentation. Now, this is an interesting study where 90 children had induced reverse Google motion sickness. For the age of 4 or 5 years, children suffer only from marked ataxia. Older children developed the complete autonomic nausea symptoms and less gait abnormality. And during adolescence, there was severe classical picture. Now, children aged 9 to 11 years, when exposed to virtual reality, had significant more postural activity, postural swing, when compared to adults. Now, there is a dissociation between the psychomotor and cognitive performance in motion sickness, and this is especially important when we deal with people who need high level of cognitive performance during their job under non-terrestrial condition, like astronauts or naval crew members or pilots. We've done such a study in an NPDL simulator of motion sickness, and we found that artificial horizon, which is a non-pharmacological measure that try to mitigate vestibular ophthalmic conflict, significantly reduced motion sickness symptoms and signs. However, it did not make better in any sense the cognitive performance tests. Now, for the evaluation of motion sickness, except for frank vomiting, all other symptoms and symptoms of motion sickness are not easy to quantify. Now, vomiting as the sole diagnostic criterion is not sensitive enough because many people suffer from significant motion sickness but never vomit. So for that, we have various questionnaires and symptom scaling that take into consideration more minor symptoms and signs of motion sickness. Now, the most practical ones are the Grable 5 category scale and Weicker scale. Now, what is the etiology of motion sickness? Now, the direct cause of motion sickness are provocative motion patterns, as first mentioned by Hippocrates. He wrote that sailing on the sea shows that motion disorder the body. This is correct also for today. Now, the common term of seasickness in Greek antiquity was nausea, deriving from the word nous for ship. Now, we have, of course, 6 degrees of motion that can affect the vestibular system. And experiments like this made on motion simulators of 6 degrees of freedom find out that the most provocative motion is around the frequency of 0.2 hertz. And when we increase the acceleration, as you can see here, up to like half G, we have about everybody essentially suffer from motion sickness. Now, the common characteristic of the provoking stimuli, is repetitive linear angular acceleration of the head. Now, the primary factor that causes motion sickness is vertical linear acceleration here, around 0.2 hertz, has been shown previously, with intensities which is decreased from a threshold level of 0.1 meter to square second. Now, separate roll and pitch oscillations do not produce motion sickness. However, the combination of roll and pitch with small heave motions, which alone are not sickness provoking, induce significant motion sickness. Let's skip this one. Now, there is habituation to motion conditions when continuous exposure to the provoking stimulus results in attenuation or disappearance of symptoms in 2 to 3 days. Habituation is a learn-centered process, and decreased susceptibility might be kept, albeit interval of weeks between sailings. Habituation to motion sickness and performance capacity are highly dependent on the personality of the individual and level of motivation. People with high motivation and those who are very busy in performing their duties during exposure to motion will suffer less than motion sickness. Now, literature shows that about 60 to 90% of novice and about 15 to 60% of experienced sailors suffer from motion sickness. And our experience is that 38 suffer from severe and 35% from moderate seasickness during first exposure to sea conditions. After 3 months of service at sea, regular sailing, we've seen significant habituation, where only 40 suffer from seasickness and 24% only from severe degree. Now, the habituation is context specific. When the adaptation is of short duration, the habituation so acquired is specific only to the prevailing stimulus. Now, when the offending motion is extended well beyond the point of adaptation, some degree of generalization to other motion patterns can occur. Now, what is the pathogenesis? Now, the best and oldest theory that explains motion sickness and seasickness is neural mismatch sensory rearrangement theory, as formulated by Risson and Brandt in 1975. And this has to do with the non-vestibular visual proprioception input which converge in the CNS and are integrated to a common signal. Now, conflict occurs when the integrated signal is found at variance with known restored motion pattern. This mismatched signal initiates motion sickness. Here we have the information coming from the eyes inherent proprioception to comparated, which has in the neural store. And when there is a discrepancy, we have motion sickness. Now, what happened is that when we have motion sickness, the neural store will be updated. And apparently, this is the reason why we'd have finally habituation to more motion conditions. Now, interesting enough, this also explains the mal-de-Barkamé phenomenon that happened after the exposure. Some people suffer from mal-de-Barkamé, like signs of motion sickness when coming back from prolonged sea voyage or prolonged flight. And this has to do with difficulty in the readaptation. Now, as the stored new pattern are difficult to get rid of. Now, I will skip this one in order to keep the time limit of the presentation. Now, interesting enough, a survey of motion sickness susceptibility made by Stroop et al. In other form in vertigo dizziness found that about more than 50% of vestibular migraine suffer from motion sickness, 48% in BPPV, 37% in orthostatic dizziness, and so forth. So we can see that motion sickness is a very frequent comorbidity in all types of vestibular deficiencies. Now, how do we treat motion sickness? First, there are no pharmacological measures. One is need to reduce conflicted sensory input, like sitting in front of the car or being on the deck of the ship, and so on and so forth. And accelerate the process of multisensory adaptation, preventing factors that might aggravate nausea, like heavy meals, etc., and promoting psychological factors to cope with the condition. Now, for the pharmacological treatment, first, I re-emphasize that functioning vestibular system is required for motion sickness to evolve. So all pharmacological agents that are effective in the prevention of active treatment motion sickness have central or peripheral vestibular suppressing characteristics. So we have cholinergic and histaminergic fibers that invalidate the transmission from the vestibular apparatus. And all anti-motion sickness effect is on antihistamines and anticholinergic medication. And this depends on CNS penetration with central inhibition of histaminergic and muscarinic receptors in the vestibular nuclei, vestibular pathways, and medullary vomiting center. Now, the most effective treatment for motion sickness is scopolamine, which is non-selective for the 5 types of muscarinic receptors. And the most popular one, which with the minimal side effects, is TTS scopoderm, which has effective prophylactic over 72 hours with minimal side effects. Now, because it needs about 12 hours to get efficient levels in the blood, we can complement it with Quells, which is per-hour scopolamine in the dose of 0.3 to 0.6 milligrams. And this will cope with the first hours when the TTS scopoderm does not take effect. Now, there are other pharmacological treatments. All of them depend on penetrating of the blood-brain barrier. We have antihistamines. The most widely used are dimenyl-dronate, meclizine, ciclizine, diphenhydramine, and promethazine. Cinnarizine has a place. This is a specific calcium blocker antagonist with H1 receptor antagonist quality, and also beta-histine in 48 milligram is also pretty efficient with no significant side effects. Now, for adult, I will just give this one and finish. So what is our treatment paradigm? We have no pharmacological measures. If they fails, it depends on the level of performance one is asked for. If we need high level of performance, we use the scopoderm and the quells or mechanism of synavism. And if if we accept high provocative motion patterns and performance is not very important, we can use oral diminutive or promethazine. If it's failed, we use two parenteral medications like Ractel or parenteral diminutive or promethazine. Thank you for your attention.
Dr. Shupak, thank you very much for the excellent presentation. We have a number of questions to you. Dr. Rohiwal from India is asking, is there any drug available as nasal spray for motion sickness?
Yes, there is, I would say, a phase 3 experiments with nasal scopolamine. Nasal spray is called scopolamine, which has a more rapid effect than the Peros medication.
So is it available in the market?
Not yet.
Not yet.
As far as I know.
Still under, okay.
Yeah, under investigation.
Dr. Singh from India is asking, can asymmetry in function between the two sides on any one or more end organs explain motion sickness? So is
Yes, this is correct. Yeah, this is correct. Now, people who has dysfunctional vestibular system but still functioning, I mean, they have some impairment of vestibular function, are more prone to motion sickness. Yes. This is because the compensation for extra environmental motion is more complicated in this case.
Okay. Dr. Lilenko from Russia wants to know, do you have any data that concern to the results of optokinetic nystagmus test by using
use optokinetic after nystagmus as a measure of the vestibular time constant. Now, the vestibular time constant decreased as habituation process in motion sickness. Also, people who have basic shorter vestibular time constant have less motion sickness.
Okay. One final question. Is this pathology, how is this pathology related to vestibular migraine? Dr. Mendoza from Argentina is asking, what is the relationship between motion sickness and vestibular migraine?
Well, the only thing I can do is cite Stroop study showing that about more than 55% of people suffering from vestibular migraine also have motion sickness. Why this comorbidity? What is the etiology of this comorbidity? I really have no idea.
So there are things to study and learn in future. Huh?
Can I have a question?
Yes, please.
To Avi. Avi, now there is an evolution technology on virtual reality and the rehabilitation methodologies. Do you think that this can be a solution in the future?
Well, virtual reality might be a solution to, I say, it's worth a trial. Because by using virtual reality, you can really manipulate the vestibular parameters. And as I've been alluded to previously, you can get more rapid habituation if you do a shorter time constant of the vestibular system. Also, this might be a very good option for special people who are prone to motion sickness and who invested a lot in their being professionals, like astronauts, pilots, etc. This might be a very interesting prospect.
Thank you.
Dr. Shupak, thank you very much for the excellent presentation and the answers to the questions. We move on with the program. The next presenter is Professor David Z. He's from Johns Hopkins University School of Medicine, Baltimore, United States. and his special interest is in vestibular disease and control of eye movements. He is one of the faculty members for 45 years. That's true, Dr. Z, is that 45 years, huh?
I'm sorry, but that is the truth.
Fantastic. And his talk is periodic alternating nystagmus and Wernicke's disease. The floor is yours, Dr. Z.
Okay, I hope you can hear me. Good morning. Thank you very much for giving me an opportunity to speak with many of my friends and with many people around the world. So a little outline of my talk. I'm just going to talk about Wernicke's disease. And this is vitamin B1 thiamine deficiency. I'll talk a little bit about its unusual characteristics. I'll speculate on its pathophysiology. Remember, I'm a neurologist, so I must put in some anatomy. I apologize. And I'm going to emphasize at the end that Wernicke's disease must be in the differential diagnosis of the acute vestibular syndrome, AVS. You never want to miss this diagnosis. Okay, I must give great credit to my colleague Jorge Cata from Peoria, Illinois, and the work I'm going to describe was all done with him and really at his initiative. I love to think about how people move. In the center, of course, you will see a picture from my last visit to Istanbul. So Wernicke's encephalopathy has a classical triad, which you all probably learned from medical school: ophthalmoplegia, eye muscle weakness, usually a 6th nerve palsy, ataxia, and a severe cognitive disorder, specifically incorporating new memories, an amnestic syndrome. Now, what are the new key features that I want you to remember if you can? There's often a horizontal gaze-evoked nystagmus. There's a spontaneous vertical nystagmus, often acutely upbeating and chronically downbeating. And when you examine the patient, the vertical nystagmus may invert its direction up to down to up with convergence, eccentric gaze, positional testing, or vibration of the mastoid. And key here is to remember that they often have abnormal vestibular function, but only in the horizontal plane, a loss of the horizontal vestibular ocular reflex with sparing of the vertical reflex. A wonderful book about this, written by Adams and Victor and Collins, is here. So 3 hypotheses, and these are my take-home messages. Number 1, there's a selective vulnerability to thiamine deficiency in neurons in the midline structures in the dorsal medulla. This is underneath the floor of the 4th ventricle. I'll show you this later. It's where the area postrema is. And these areas control vertical gaze holding, and they control horizontal gaze holding, and they control the horizontal but not the vertical vestibular ocular reflex. Number 2, the lesions of the affected areas in the area postrema, in the dorsal medulla, is related to abnormal, imperfect blood-brain barrier. This is where the blood-brain barrier in the brain can become defective, and this has marked effects on astrocytes, mitochondria, excitotoxins, etc. And finally, the 3rd hypothesis is that the characteristics of the vertical nystagmus in Wernicke's, downbeat, upbeat, changing, relate to involvement of otolith ocular reflexes. We normally don't think of them so much, but the translational reflex is used to compensate for eye movements when we translate our body side to side, up and down, fore and aft. And this is part of the problem that causes these characteristic defects in Wernicke's disease. Now, a couple of videos, let's hope they work. One is show the conversion of spontaneous nystagmus in the straight ahead from initially upbeat to a permanent downbeat. Now, what we're going to see here is a man early on in the phase of his disease. And if you look carefully, you'll see a little upbeat nystagmus. Watch the lids. That's almost the best way to see an upbeat nystagmus. But it's beating up. And when he looks to the side, it becomes even more apparent, beating up. Watch the lids. And this is so characteristic that these vertical nystagmus gets worse on lateral gaze. Looking up, he has some upbeat nystagmus. So this we may see in the acute phase. There's an upbeat nystagmus again. Even when he looks down, it's upbeating. It changes with convergence. Now we're a few years later. I don't see much nystagmus straight ahead now. When he look, a prominent downbeat nystagmus. So he has changed from upbeat acutely to a downbeat chronically. Okay, now the next new finding is that there may be a switch of upbeat to downbeat with various provocative maneuvers: convergence, head shaking, position changes, looking to the side, and vibration on the mastoid. Now we have an upbeat nystagmus, and then we're going to vibrate on the vertex, stops and becomes a little downbeating. So very curious finding by using a vibrator, very distinctive for these patients with acute upbeat nystagmus. Here's a few more cases. Chronic Wernicke's disease. It's beating down. Beating down. And again, much worse on lateral gaze, but still beating down. And here's another patient with acute Wernicke's disease with hyperemesis gravidarum. She was pregnant, vomiting. And here you see that the prominent horizontal component can be there acutely. There it is. So we've seen acutely horizontal, we've seen acutely upbeat, we've seen chronically downbeat. Now, important case. This is the change in the vestibular ocular reflex when you do the head impulse. We'll do a slow and then a fast vestibular head rotation. So there's no vestibular ocular reflex. The slow phase is absent. There's just little saccades. Now we're going to do a head impulse, no response. It's absent horizontally. I don't have a video of this patient here, but it's present vertically, absent horizontally. Here's some work from Turkey by Gildan Akdil and colleagues, which shows some recordings of a patient in the early phases, acute Wernicke's encephalopathy, horizontal affected, vertical spared. There's a horizontal reflex, right and left lateral. You can see the blue, a very poor slow phase, and lots of corrective saccades. The red spikes show corrective saccades. And then vertically, she's virtually normal, both anterior and posterior canals. Here are the MRI changes in Wernicke's disease, just what you would predict from the clinical findings. The abnormality is in the floor of the fourth ventricle, just underneath, where the structures for horizontal, in this case, gaze holding, and horizontal vestibular ocular reflex, the medial vestibular nucleus, the nucleus prepositus, are located. One more case, a young boy, several months of anorexia, stomach discomfort, and nausea, came to the hospital, put on IV fluids with just glucose, a big mistake. One morning, he was found to be confused and unsteady with ophthalmoplegia and absent doll's eyes or a VOR. He was given thiamine. The video's a few days later. There's our gaze nystagmus again. Some upbeat nystagmus. No ophthalmoplegia at this time. No classical sixth nerve palsies. Now you'll see when he converges, he now has a downbeat nystagmus. So again, this changing with convergence is extraordinary. Here's his MRI, 24 hours after onset. You can see all that T2 signal by the arrows in the paraventricular areas, both in the medulla and up near the thalamus. This is where the blood-brain barrier is most susceptible to leakage. And then here's 3 weeks later, the abnormalities are almost gone from this patient. All right, let's analyze these cases. The first question, where are the lesions? And they could be anything that cause upbeat nystagmus, that cause horizontal gaze-evoked nystagmus, and cause an absent horizontal but a spared VOR. Again, they are all in the floor of the fourth ventricle. Here's an example of a patient with upbeat nystagmus. That's the floor of the fourth ventricle, and the lesion is in the, if you will, nucleus intercalatus, Statarini, in the medial medulla. Another important set of nuclei, we've already talked about them. We saw that they were abnormal on the MRI scan, the medial vestibular nucleus, the prepositus nucleus. There they are medially under the floor of the fourth ventricle. And these are the reason these patients have the horizontal gaze abnormalities, gaze-evoked nystagmus and the abnormal horizontal vestibular ocular reflex. Look what is spared. The superior vestibular nucleus, the Y group. These are structures far from the blood-brain barrier, and they mediate the intact vertical VOR, and that is spared. Now, one other structure, just two more anatomical structures to keep you awake. There are the paramedian tracts, which are also located medially. They are affected acutely. They project to the cerebellar flocculus. These are the paramedian tracts. So, what do we see with the lesion in the cerebellum and the flocculus? We see downbeat nystagmus. Here's an example. And this is a downbeat nystagmus with a flocculus lesion or cerebellar lesion. There it is. So how does this all account for why do we go from upbeat to downbeat? The initial lesions are in the perihypoglossal complex and the paramedian tract nuclei immediately. This causes the initial upbeat nystagmus. Part of those structures, the perihypoglossal complex, recovers, but the paramedian tracts do not, leading to an enduring downbeat nystagmus. The PTN, the paramedian tract lesion, is permanent, and therefore you lose excitation of the flocculus. So I'm going to finish up on time. Just a few more points to make. Here's our summary. Initial upbeat due to involvement of the midline structures. When they're damaged, we get upbeat nystagmus. The perihypoglossal complex recovers. The paramedian tract nuclei do not, leaving a net bias with an enduring downbeat nystagmus. And there's a selective vulnerability and selective recovery of the circuits involved in vertical gaze holding in Wernicke's. Again, abnormal horizontal but normal vertical VOR and horizontal gaze-evoked nystagmus reflect involvement of the medial structures, sparing of lateral structures. These structures are near the blood-brain barrier, and we have evidence that when there's thiamine deficiency, it breaks down first. All right, it's an absolute emergency. Classically, of course, they have ophthalmoplegia, but they can have nystagmus of any type, horizontal, vertical. We see B1 deficiency in a lot of circumstances: alcoholism, eating disorders, vomiting, B1 deficient formula in children. That was reported in Israel. After special procedures for obesity, even just living alone or giving glucose, treat immediately. It's an emergency with thiamine and magnesium if necessary. If you don't treat, you get a permanent ataxia, nystagmus, and a severe cognitive dementia and amnestic syndrome, Korsakoff psychosis. Recognize and treat. So, Wernicke's encephalopathy, a neurologist's dream. Anatomy meets physiology, meets pathology, meets diagnosis, meets treatment. Recognize this disease. You must include this in the differential diagnosis of acute vestibular syndrome. Thank you.
Professor Professor Z, thank you very much for this excellent presentation. I think you used the videos to demonstrate the pathology in a very elegant way. Thank you for that. We have a couple of questions, one from India, Dr. Kassad. Are there any unusual eye movements seen when patient is under hangover or alcohol excess? Can excessive drinking cause any permanent vestibular or balance disorder?
So this is an excellent question. What about alcohol per se? So 2 points. Sure, alcohol causes nystagmus. Of course, these patients with Wernicke's disease, when we're seeing them, they are supposedly not on alcohol. And with alcohol, chronic alcohol, you may get some cerebellar degeneration and you may get some downward beating nystagmus. But remember, these patients were seen initially with upbeat nystagmus, not with downbeat nystagmus. We cannot exclude that there was some contribution of an alcoholic cerebellar degeneration to the chronic downbeat nystagmus, but not to any other features of this syndrome.
Thank you. The second question is also from India. Does thiamine deficiency have any impact on the peripheral vestibular system?
Well, yes, the thiamine deficiency, but it's often associated with other kinds of deficiency as well, of course, you know, pyridoxine, et cetera, can cause some peripheral neuropathy. So that is a part of a feature of chronic alcohol use, and presumably some vitamin deficiencies may also contribute to this.
Another question, in a patient, what should make us suspect Wernicke's encephalopathy?
So a patient is brought to the emergency department. They're having trouble walking because they have a vestibular deficit. They're put in the back of the room. They are not excited. They are not hallucinating. They have a quiet, apathetic state. This is the constellation of symptoms. And if they have any eye movement abnormalities, any change in cognition, you must recognize this. And remember that young boy, he did not have Wernicke's disease when he was put into the hospital. He had a lot of gastrointestinal vomiting. For 5 days, they just gave him glucose, no other vitamins, and they put him into a Wernicke's encephalopathy. So any patient who comes in who's been on a glucose diet, I had a patient on an ice cream diet for 2 months, and then she went on a race, a jogging race, a young woman, and she developed Wernicke's disease. So please, not just glucose in your diet.
One final question from Russia, Dr. Linenko. Could you tell us your opinion on multidirectional spontaneous nystagmus by using VNG in peripheral and central vestibular dysfunction?
If you give me 48 hours, I'll be happy to answer that question. He can send me an email and we can correspond on that, but I'm sorry, I think we must listen to John Rutka next.
Dr. Z, there are many notes thanking you for your excellent presentation.
Well, I enjoyed it. I always appreciate it. I miss not being in Turkey because I like the food, though. This is a problem with Zoom.
Yeah. Okay, that's good. Thank you very much. So the final presenter at this time is John Rutka, professor of otolaryngology in the University of Toronto. He's an otologist and neurotologist. The special interest is topical and systemic ototoxicity, also canal-based surgery for dizziness. His talk is about recurrent vestibulopathy. Dr. Rutka.
Thank you very much, Levant, for the nice introduction. And welcome to everyone from sunny Toronto. It's very hot here, just like in India, where most of you are listening from. Thanks to the organizers and conveners, and thank you, Dr. Z, for at least mentioning my name. My mother will be very appreciative of that. Anyway, I'd like to talk about something that's a bit more common than Wernicke's encephalopathy, which is something called recurrent vestibulopathy. Some of you may have heard the term before. Some of you may have not heard the term. but actually I think it's quite common. So if we look at the actual definition of this condition, what we're really looking at is we're looking at a disorder that we believe arises either from the inner ear itself or possibly from the actual vestibular nerve. And by definition, it's a condition where you have recurrent bouts of episodic vertigo, similar in duration to what you see in Meniere's disease, but without the auditory symptoms such as tinnitus, perhaps oral pressure, fluctuation to hearing, and there's no evidence for focal neurologic dysfunction. Now, this is a condition that was, I think, promoted by someone called Hugh Barber. He was my former mentor in Toronto, and at the time when he was certainly around in North America, was considered one of the great clinical leads in medical neurotology. And he was specifically bothered by the fact that he saw a group of patients who didn't have Meniere's disease, but they kept on presenting with recurrent bouts of episodic vertigo, very similar. And he followed these patients for many, many years to see what happened to them. And I think that's the gist of my lecture today, is to show you, in fact, what did happen to them. Now, when Hugh examined them, what he found is that the physical examination was unremarkable. All the vestibular provoking tests were normal. There was no evidence of neurologic dysfunction. And about 20% of people in those days, when all we had was the ENG, demonstrated a unilateral caloric reduction. Otherwise, the imaging was normal. Everything else seemed to be normal as well. So Hugh described a condition, and it was mostly a descriptive term, recurrent, because there were lots of attacks of vertigo, and there was something going on inside, he thought, the vestibular system, and that's how we get the term recurrent vestibulopathy. You might know this by another name, depending on where you practice. Some people call it episodic vertigo. Some people have called it vestibular Meniere's, benign recurrent vertigo, so on and so forth. The diagnosis that I love to point out is something called amigranous vertigo, where people say that, you actually have migraine causing the condition, but there's no migraine. Meniere's an evolution, and sometimes an atypical variant of what they call familial episodic ataxia. Very curious condition, but really not much has been written on that since about 2008. So when I teach the residents in our training program at the University of Toronto, I usually put up this slide. I call it the Rosetta Stone. It basically looks at really quite common inner ear disorders, and the four that are really common that we see in clinical practice are Meniere's, benign positional paroxysmal vertigo, which is obviously the most common, vestibular neuritis, and recurrent vestibulopathy. I have also included acoustic neuroma, only just so that you don't forget to look for something like a space-occupying lesion. But if you look at Meniere's disease, for example, you have attacks of vertigo that go on for minutes to hours. There should be hearing loss and tinnitus. If you look at recurrent vestibulopathy, you have the same attacks that go on for minutes to hours, but there is no hearing loss or tinnitus itself. And I have used this slide to try and teach the residents, basically the gist of neurotology. Now, we do have other types of vestibular dysfunction, and we've had a lecture on ototoxicity already today. Delayed lymphatic hydrops, which is basically attacks of vertigo, but in someone who's deafened on one side or perhaps both sides. Other things such as drop attacks, surgical complications, canal dehiscence syndromes, and don't forget neurosyphilis. What we have done at our institution in Toronto is that we've been pretty good about keeping track of patients, and we have a multidisciplinary neurotology clinic that contains neurologists, otologists like myself. We have a vestibular psychiatrist, we have physiotherapists, we have our residents, and we have our fellows. And in about the mid-90s, we looked at our first 1,000 patients that went through this multidisciplinary clinic. Everyone's seen at the same time in a one-stop shop. And what we identified is that most of the conditions that we saw were basically peripheral vestibular in nature. Some were central, some were mixed, in other words, central and peripheral. Some were psychogenic, and then heavens knows what some people complained of, and they were the unknown category. But if we looked at the common inner ear problems that we saw in this clinic, what we identified is that over 50% of the time, a diagnosis could either be made for benign positional vertigo or this condition called recurrent vestibulopathy. We spend a lot of time talking about Meniere's disease, but it is relatively uncommon compared to all the other peripheral vestibular disorders that you typically see. The other thing we found out, which I think is important in the context of this discussion, is that in any individual, it's not unusual for more than one peripheral vestibular disorder to be present. So if you see someone with vestibular neuritis, perhaps months, if not years later, they might develop positional vertigo, and they might develop something like a recurrent vestibulopathy. And in fact, 15% of people with Meniere's disease that we have looked at will have concomitant benign positional vertigo. And in our first 1,000 patients, 12% had more than one type of distinct inner ear problem. So again, you see the spectrum of inner ear disease in any patient in some instances. So anyway, Dr. Barber coined the term recurrent vestibulopathy. I've given you the definition above. But what did the long-term studies show? And this is really important because in medicine, we have short-term studies of a year or two. As you know, we don't have long-term follow-up in most of the patients that we see. What happens to these people? Well, what Hugh Barber did is he was very good about following these patients for a number of years. And so after an average of 8.5 years, he followed a group of about 70 patients who had recurrent vestibulopathy. He found that 60% went into remission, and it didn't matter what you treated them with, they went into remission, literally. 10% continued to have active attacks. 15% evolved to Meniere's disease. 10% developed positional vertigo, that's the spectrum that we identified, and 5% had some type of unknown peripheral vestibular disorder we felt by history. But none developed evidence of central nervous system dysfunction. There were no brain tumors, there was no MS, there was nothing bad or worrisome. So that's really important when you see a patient with this sort of problem. In looking at the world literature, there have been other authors that have published on recurrent vestibulopathy. From Northern Europe, we identified one study, and this was published in the JLO, looking at 105 patients. 2/3 seemed to resolve within 1 to 5 years, and 2% changed the diagnosis to vertiginous migraine. So not very many actually had, episodic vertigo associated with migraine. 1% evolved to Meniere's disease. And in a study from South Korea, in laryngoscope, they looked at almost 100 patients. Females were more commonly involved than males with this condition. There was a caloric reduction of 25%, which is very similar to what we saw in Toronto. 82% of their patients resolved. Another 12% continued to have active attacks, and then some evolved into actual Meniere's, but it was the minority, not the majority, if you follow these people long enough. So one of the interesting things that I did is I decided I'd do a literature search. We're very, initiated with the concept of vestibular migraine. We even had a panel session earlier today, and I do apologize, I didn't see it because I was sleeping. Over here on my side of the GN, I guess Greenwich Medium Time, it's about 7 or 8 hours difference. But what I did is I just wanted to see, in fact, how many papers were published looking at recurrent vestibulopathy, looking at recurrent migraine disorders and vertigo. And as you can see, there's probably about a 10-fold difference over the last 45 years in terms of publications looking at vertiginous migraine versus recurrent vestibulopathy. So I think our profession, and certainly neurologists and neurotologists, are probably more keen to make a diagnosis of vertiginous migraine, perhaps if they see someone who has episodic vertigo, possibly, if it doesn't fit the diagnostic criteria of Meniere's disease. But it was just an interesting finding to identify that. So it may be a new diagnosis for you to consider if you haven't heard of it before. In some ways, recurrent vestibulopathy is a speculative diagnosis. We do not have definitive histopathology as we see, like in Hydrops and Meniere's disease. I think that patients and physicians want to give their patients a diagnosis, obviously, and patients want to have one as well. And perhaps it's easier to accept the fact that, yeah, you have a vertiginous migraine disorder versus, well, you have some inner ear problem. We don't know what's causing it, but we do know that it will get better with time. And a lot of it will also depend on, obviously where you trained, who your mentors were, and your own clinical experience. But if you are going to say that a patient has vestibular migraine, may I just ask that you please reflect back on the consensus document of the Brownie Society as how you diagnose vestibular migraine. And please use that as your diagnostic criteria if you're going to say to that patient you have vestibular migraine rather than a recurrent vestibulopathy, in the absence of headache especially. And remember that sometimes we associate the two together because they are very common. And there's a commonality in the sense that they're both episodic recurrent conditions. They tend to be benign for the most part, many times goes away on its own. And sometimes we marry the two together in the form of convenience. And so, again, I just ask you to be, again, just a bit more observant, take a good history. And if you believe they have vestibular migraine rather than recurrent vestibulopathy, at least use the Brani Society criteria. And that's really the end of my talk. And I thank you very much for listening to me.
Thank you very much, Dr. Rutka, for keeping on time and giving this precise information. There are a couple of questions, one from Algeria, Dr. Aloun. In conclusion, recurrent vestibulopathy is a cause or a consequence of inner pathology. Is it a cause or consequence of a pathology? That's the question.
Well, we don't even know what the pathology is. The speculation by Hugh Barber was that it may represent transient deafferentation of the vestibular nerve, as there is no evidence of inner ear pathology like hydrops, for example. If you look back at the history of attacks of vertigo without hearing loss, we spend a lot of time looking at vestibular neuronitis, which is a very spectacular form of dizziness. And we do have some histopathology on that. And if you look at Cedric Coates, when he first published on vestibular neuronitis, he called it vestibular neuritis, not neuronitis. And what he looked at was both these attacks that were episodic and frequent, lasting from minutes to hours, and also the very prolonged attacks that went on for days and days and then gradually got better. Somewhere along the line, we forgot about these recurrent attacks of episodic vertigo that weren't associated with either hearing loss or focal neurologic dysfunction. And that is what we mean by recurrent vestibulopathy. And again, some people have attached the word, vestibular migraine to that, or they've attached, amigranous vertigo to that. And I just want you to make sure if you're going to make a diagnosis, please use the criteria that are available.
Dr. Dutta from India is asking how to differentiate between recurrent vestibulopathy and vestibular migraine clinically through clinical history and physical examination.
Read the Brani documents. They're there already. And just please remember that, you can tell. I mean, the good news is that with regards to recurrent vestibulopathy, I don't think it matters what you do. These patients will probably get better and go into remission given time, but you have to be there and supportive for them and make sure you're excluding serious pathology that causes issues. You can treat them if you want to, as if they have vestibular migraine, but I doubt very much they're going to get better with the migraine treatments. It's a different pathology, I suspect.
Dr. Balkan from Turkey is asking, do you have vestibular epilepsy patients?
Very rarely. I think of maybe the 4,000 patients we've seen in our multidisciplinary clinic by now, I think we've made only a diagnosis at once. But, like everything else, sometimes when you get to the end of the rope, you're willing to try anything. And sometimes we will try an anticonvulsant to see if that helps.
From Italy, Dr. Castellucci, are there any instrumental hallmarks for recurrent vestibulopathy, such as head impulse test, WEMS, calorics, and so on and so forth? Instrumental.
Yeah, that's actually a great question. You know what? We did a lot of work on this really early on in the 80s and 90s. All we had was the ENG, and that's where we found about 20% of our population had a caloric reduction. You can go ahead and do the VEMP and obviously the VHIT studies. We haven't done them personally, or at least we haven't kept track of them in terms of publishing on them. And yes, there's no reason why you couldn't have some vestibular impairment as well, involving both the otolithic organs as well as the semicircular canals. And sometimes we have what they call a recurrent vestibulopathy with prominent otolithic features, more of a rocking sensation that'll go on for minutes or hours and goes away, but it's episodic in nature. Sometimes it's actual spinning and circling, which suggests more of a semicircular canal-based problem.
One final question from Iran, Dr. Okovat. What would be a good approach to prevent repeatedly treatments for a patient with frequent recurrent symptoms? How can we prevent these attacks?
Well, I think what we often do is by default, we treat them as if they have Meniere's disease medically. Whether they get better because of that, that's a different story. Remember, these attacks come and go, and it depends on the frequency, obviously, that these patients are, involved with in terms of their attacks. Like most things in life, lots of unanswered questions in otology, neurotology. It's a big black box, lots of stuff inside, but not much knowledge.
That's right. That's right.
Yeah.
I have to thank you. You have done a very good job. You have done excellent presentations. I'm sure people all around the world enjoy the presentation knowledge, and they ask many questions to you. We benefit a lot from the talks, and I think it's time for me to close the session and hand over to Dr. Özgürgen. Dr. Özgürgen, by the way, when is the gala dinner tonight?
Oh, we are having our wines at our.
People are asking
Yes,
when
yes,
is the
yeah.
time for gala dinner.
Yeah.
What can we give an answer?
Dear friends, thank you very much. It has been a great session, and I especially wish to mention my sincere thanks to David and John as we disturb their sleep of this night. Thank you for all of you for being here, and that was a great session with a very high scientific level. Thank you for coming, and looking forward seeing you in Belgrade. Thank you.
Thank you.
Thank you.
Bye.
Bye.